Good morning, everyone. Is that all you can manage? Good morning, everyone. Good. Right. See, Michael told me that it would be a rousing crowd here, right? And of course, I'm from California, so you know what time it is, right? So I need the inspiration here. Thank you very much. You know, when I first met Michael, it was very shortly after his bout of treatment for non-Hodgkin's lymphoma, and you know, you could see this young man, you know, with some fire in his eyes, right? He just had fire in his eyes, and you know, you couldn't help but listen to what he was trying to get us to grapple with. You know, and so it's really amazing to see. I guess 15 years later, Michael, 15 years later, you know, all of that has gotten translated into this deeply passionate mission, really, to help us as healthcare providers listen to our patients, teach our patients, communicate with our patients, partner with them to get them to a better place, to be healthier, and that's really amazing to see this enormous progress, Michael. You know, of course, you know, you always have to go to your own personal experience as a patient to understand the deep motivation that gets us to this point. And you know, I was telling Michael earlier that, you know, I actually wasn't treated for cancer early in my life, but as a medical student, I actually had some valve problems as a kid, and as a third-year medical student in the middle of my OBGYN rotation, catching babies, I almost missed the baby because I was shaking so much. I had shaking chills, and turned out that I had endocarditis. And those of you know, in the 1970s, endocarditis was treated with IV antibiotics for 28 to 4 weeks to 6 weeks, and so I was actually hospitalized in a very, very good, prestigious academic medical center. And some of you may know that with endocarditis, after the first day, you feel totally normal, right? You just feel great. So I felt great because I wasn't shaking anymore, and I just wanted to go out and do something. Of course, at that time, everyone was so conservative that no, you could blow out your heart, that infection could just, you know, run rampant, you could die, all of that stuff they told me, right? This was really interactive patient care at its best. And of course, you know, for 28 days, all I had to do was sit there, argue with the medical students that would come and try to draw my blood every day. You know, you did this yesterday, how much different could it be? And I even offered to have a heparin lock. I promised I'd come back for this every day. And of course, today, that's what we do, right? We send people home. We send infusion nurses to their houses if they're not reliable, or we have them come back and do that. But it was 4 weeks, 28 days on the ward, nothing to do. I actually even said, okay, let me go down to the lectures, right? Because we were in a medical school after all, but they wouldn't let me do that. So we all have these stories about being patients, being in that on that other side of the provider-patient continuum, and when you're on the other side, you really begin to understand what the needs are, right? So I actually appreciated what Michael did then, almost probably 13 years ago is when I met you, Michael, and actually I'm amazed at how much you've all embraced this mission. So it's a real privilege for me to come and speak to you about, you know, some of the ideas that I think, you know, we're all grappling with. I know that Michael yesterday was talking about where the whole interactive patient care is going. And so what I thought I'd do is talk a little bit about some of the work that we've done to chart a pathway for Kaiser Permanente that may offer some ideas on how we might expand interactive patient care to another level. So Just a quick summary. You know, Kaiser Permanente, we are the oldest group model health maintenance organization in the country. We recently topped 10 million members who we serve in 7 regions. I'm the regional president for Southern California, and we just topped 4 million members, and of course the Georgia region. We have, as you can see, one of the things we've done is we've made a big investment in health information technology, and that actually has helped us move our system down up to a different level. So the thing about 4 million members is that, you know, and I've been there 10 years, and in that 10-year period, we've grown in Southern California 1 million members. Now, when I say members, I mean they're in our health plan, but because we're a group model health maintenance organization, we actually have to provide the care, the full continuum of care for 1 million members. So you can imagine how much we've been scrambling to actually get capacity in place to begin to take care of that many people. By the way, 4 million members, just to give you an idea, 4 million members, and that translates into only 250,000 hospitalizations a year. So you can imagine where we're going, where we have to go, if we're serious about interactive patient care and interactive patient education. Most of the care is outside of the hospital, and that's what we began to realize. So we started out this whole effort probably 3.5 years ago. And I know there are people from Kaiser Permanente out there in the audience. I actually sort of see the top of your heads there. Okay, so, and you were part of this, so you know, you can correct all of the mistakes I make up here. But we started out thinking, how might we design the medical office building of the future, right? The medical office building of the future. And of course, usually when you do that, you know, you go to user groups, right? How many people have actually done facilities, you know, been part of that? Well, if you have, they usually go to the user groups, right? The doctors, the nurses, everybody who does that care. But the problem with going to user groups that are just providers is it's only one user group. It's only one part of the whole continuum. So we ended up thinking about, well, how might we design not the medical office building of the future, but how might we design the future? And the reason why and I'll tell you why, the approach we took, but we were sort of struck by Henry Ford's comment that if I had asked people what they wanted, they would have said faster horses, right? And so in some ways, I don't want to say that user groups are you know, just would only talk about faster horses, but providers, we're sort of trapped in our perspectives, right? We work very, very hard. We work in our general departments, and very often we work in silos, and we don't often think about what else can happen, right? So I think that this was sort of a very apt quotation. So how did we do this? Well, we started with member insights, you know, sort of exactly what you guys are talking about with your interactive patient care, right? We went to about 150, both members and non-members, and just hung out with them in a way. We just hung out. We went and we talked to them to try to uncover what were their unarticulated, unmet needs, and to really begin to gain some empathy for the experience of our members coming through the system. And we use this human-centered design as our approach to thinking about how we're going to do things differently. By the way, we sort of held back on a lot of projects because we wanted to actually take this approach to building new projects. And you can imagine when you're growing as much as we do, there was a lot of pent-up pressure to get a building up there. Just let's get an office, get something. But we actually took the time to do that. And so we ended up talking to 150 members and non-members. And we use video ethnography. I don't know if many of you actually have been using video ethnography. It's a very powerful tool, where you actually just sort of, do the discussion, but you tape the interview in a way so that you can use it later on to illustrate what the members meant. And so that's one of the things we did. And really the reason we did that is that in order to get to where we wanted to go, we realized that it had to be we had to reach out for diversity of thought, much more experience, and then begin to plan from that point of view. So we did the field work. We actually tried crowdsourcing with all of the tools that you can do with the digital revolution. We had ideation sessions involving patients and many of our providers. We tried things out. We got frontline input. We actually ran a number of boot camps where people. It's really fun to do this, where not just the stickies, where you got stickies all over, but people created these sites. What would it look like, and they actually play acted what it would happen. It was sort of fun to do this, to tell you the truth. So all told, over 1,000 participants in the process to get to the design. So just to give you the framework on where we came from and where we're going, right? Today, you think about our members, right? Our members or our patients or our consumers, however you want to talk about the people that we interact with and we want to influence. It's just a sliver of time that we spend with them, right? And of course, one of the reasons to focus in on the hospital is that it's a particular time where patients really need care, and it's a great time to focus their attention on health and all of the things that they can do to get healthier. But really, when you think about it, it's a small sliver of time for the overwhelming majority of people. Most of us fortunately are healthy most of our lives, and so we don't interface with the healthcare delivery system on a continuous basis. So it's just that one sliver. And in the outpatient space, the average American sees a doctor 4 times a year. Not only that, they don't even see the same doctor 4 times a year. So you think about that 15-minute slot 4 times a year, an hour a year, a minuscule amount of time, if you think about it, to be able to be interactive and influence people's behaviors and all of the other things that could lead to a healthier life. So today, that's where we are. Tomorrow, and they, of course, this is their domain, but with this life integration, and I actually titled the talk "Towards the Vision of Life Integration," trying to reimagine health and reimagine care. This is what we want. Our Kaiser Permanente, or all of us who are in healthcare, we want to increase our domain. We're not asking our patients to move to us. We're actually trying to expand our domain so that we integrate more with their daily life, right? So that's the overall concept. And the design principles and the paradigm, really the underlying principle is to interweave into people's daily lives the notion of health and all of the things they can do to stay as healthy as possible. And in order to do that, if you actually look at our systems now, it's not really intuitive, right? So these are the 3 principles that we came up with, that whatever system that we want to put out there has to be intuitive. Resources have to be easily accessible, understandable, convenient, and intuitive to navigate. Pervasive. You can't really think that we're going to integrate into the life when all you have is that one big hospital fortress somewhere where somebody has to drive over an hour to get to. Can't find parking, like in California, we can't find parking, right? I know Maggie's laughing there because she's always asking me to build a parking structure for her. And so pervasive meaning services are brought closer to where our members are, and also made much more available. And then aspirational, where we talk about inspiring our members and the broader community, because it's not just our members alone, but the communities where they live, where we have to begin partnering with them to weave into their core values the notion of better health, and recognition that it's not just the medicines we give people, but there are a lot of other determinants in that health paradigm. So this is where we got to. If you think about where our space right now, we are down. I don't have a pointer, but we're down in the hospital space, maybe in the clinic spaces, and we're really in the illness space, right? And if we're serious about moving up to wellness and better health, not just better health care to get people out of their pickle that they're in when they're sick, we have to think about how to move beyond, use the tools that are now currently available to us, and there are many tools, a lot of digital tools that allow us to reach beyond the four walls of our hospitals and office buildings, and to break down not just the geographical barriers, but the temporal barriers, right? When you think about it, we're no longer confined to a face-to-face visit. We can use lots of digital tools to expand almost 24/7 our ability to interface with our members. They may not want us to interface with them 24/7, but we're actually able to do that. And so that's why we thought about the whole variety of platforms, and really we came up with. Remember, I told you this was in the beginning how to design the medical office building of the future, and very quickly, after listening to our patients, and really actually after listening to our providers and all the frustrations that they had with actually being able to influence our members, we settled on 5 different platforms that we thought were going to be essential in our enlarged approach. So and the Health Hub, which is the medical office building, is just one of the concepts. We talked about, and I'm going to go through all of these very quickly. Blink, which is a much more, well, I'll talk about it in a moment. Blink, MedKit, Pivot, and Cultivate. So let's go to MedKit. A MedKit lets the members take care of themselves while remaining confident they are always being taken care of, right? So it's sort of like what's available to our patients and our members at their fingertips. We want it to be personalized and powerful, accelerate clinical expertise, and prompt issue resolution. There's no reason why people actually have to come in for a face-to-face visit to get resolution of a lot of the problems that they have. And we need to use technology to empower different choices and different access points, and seamless navigation to get the right care in the right venue. And these are some of the options, as you know. Well, one of the great revolutions now is the smartphone, right? Just about, actually an amazing number. I heard a statistic that 80% of the American population actually have smartphones, or will have it very shortly. So the ability to be mobile and to connect allows us to do a lot of these things. So these are some of the things these are some of the properties or characteristics we want to build into this MedKit. Intuitive navigation, so we could figure the people at home can begin to figure out what the right venues are, and if they need to, we can assist them to get there. Perhaps symptom checkers, so to allow people to answer their own questions if they just have a question about something that's going on. Different options for them, either as well as do-it-yourself types of remedies, at-home remedies. We have a treasure trove of patient health education materials online now, and we can actually begin to build it into mobile applications that give people that access. Ability to get connected if our members need an actual face-to-face visit, and more importantly, I think, is the ability to connect with us either through telephonic visits or video visits if that's necessary. Navigation tools that allow people to know where we are, where they could go. And then the nice thing about having made that $4 billion investment in our electronic health record is we can actually figure out how to integrate that with our electronic health record, right? So, this is just an example of some of the things that we've already got in place, but there are many, many more things that we'll be integrating into this med kit. I mean, right now, all of our members have the ability to call into a nurse call system. We're developing a teledoc capability. Some of you may know what that is, where if you need a telephonic or a video interface with a doctor, we're actually now beginning to relay you to that person without having to come in. We have a lot of virtual activities that are increasingly becoming more sophisticated, dermatology, other kinds of things like that, where we're probably going to be weaving more and more of those activities into this MedKit operations. Blink, very quickly, Blink, the concept of Blink is a pervasive, convenient network of nurse-run clinics close to where people live, work, and play, and that focuses on rapid issue resolution, health, wellness, and prevention, right? So that's the overall concept. And the idea is to maximize value, clinical accountability, maximize the scope of practice for our nurses and nurse practitioners, unparalleled service, timely and effective, rapid issue resolution. They should be transparent, simple, familiar, strong community integration, and technology enabled, where we actually will be building telehealth linkages to other levels of care if the member needs that. The idea of, and we're just beginning to roll some of these out, and I'll give you some examples. I mean, in the ideal setting, it should be a place where people feel comfortable convening, and where health education, clinical care, community engagement all come together. One of the ways we started doing this is in Southern California, we partnered with Target to do 4 Target clinics, this Minute Clinic movement. We are actually running 4 of the Target clinics, 2 in San Diego, 1 in the Inland Empire, and 1 in Orange County. And they are really going very, very well. Our members go to them, non-members go to them. Took a little while for us to negotiate contracts with other payers to pay the fee, but it's part of the whole concept of being much more pervasive, much more in the community, much more integrated with day-to-day activities. Pivot is a wellness-based social movement that uses partnership models to drive health reinforcing behaviors. And here, there are a lot of tools. I mean, social networking, social networks are out there. I mean, Patients Like Me, most of us know what that is. There are lots of different venues that we could create or we could tap into that allow for peer-to-peer, member-to-provider, community partners all interacting with each other and collaborating with each other to build on the whole common mission of trying to get to a healthier overall community. It's a member-driven, purpose-driven, small groups. We have the capability of allowing people to see their health data. We could begin to integrate, the whole movement to quantify ourselves, right, with Fitbits and those kinds of things. So that's the idea behind Pivot. How do we utilize all of these new tools, all of these new approaches to get people engaged in a more comprehensive dialogue about health and the health habits that will contribute to a healthier overall life. And I'll just go through this. And one of the things that we're doing, by the way, is beginning to think about how we pull together our services. And this is a service that we're just beginning to put in, trying to pull together our approach to our members with Parkinson's disease. You know, the traditional medical model is very, very individual oriented. You see this person, you might go to physical therapy here, you might have some calibration of your medications in other venues, but it's very often not coordinated, right? And one of the ways to bind everyone together is to build a platform that actually houses our member, that our member can interface with the various components of our delivery system to educate not only our member, but to educate us about what's going on with the member, and then to pull in the resources to begin to think about how we optimize the function for those members. And it'll allow for peer-to-peer types of interactions because, you know, with Parkinson's disease, one of the biggest things that happens as people get progressively worse is the depression that sets in, right? Depression and social isolation that fuels that downward spiral in a lot of ways. So this has actually been going on in the Netherlands. We imported their approach, and we're going to try it out. And of course, if this works, there's no reason why you can't develop groups for multiple sclerosis and a whole host of other conditions when you think about it. And that's what the new digital revolution enables us to think about if we're smart enough to think about using the tools and configuring our programs in that direction. Cultivate. Now, cultivate is a different concept. You know, the idea that we as healthcare providers could provide all of the services to keep our communities healthy is probably, you know, a wild concept if you actually think about it, right? Because if you believe what I say, that our interface with our members, with members in the community, are only a fraction of their total life, we have to actually think about how other assets in the community contributes to getting to where we want to go, right? When you just think about it, even if you think about people, our patients with chronic illnesses, I mean, the healthcare system, the medical model only gets us to a certain point. There are all of the social aspects, the social support systems that are absolutely necessary to support not only our members, but the family members who really spend most of their time taking care of our sick individuals. So it's really a concept of how do we bring in community resources, coordinate them, make it easy for people to get the resources that are necessary, and how do you actually get the rest of the community to think about health as one of the primary core principles and core values, right? Because, you know, it's not always the top of mind for most people in the community. So it's an intentional and integrated community health improvement strategy, elevated as a core business imperative with shared accountability across the enterprise. You know, we, as most of you, I don't know, those of us who are not-for-profit, we spend a certain portion of our margins on community benefit, right? So, and at Kaiser Permanente, we spend about 4%. Well, one of the questions we're asking is, well, what about the other 96%? I mean, that's a huge amount of dollars. I mean, our revenue base is now close to $60 billion. So how do we actually leverage all of our spending to drive a message of healthier communities, right? And that's sort of the notion that healthcare institutions can be anchor institutions in the community to begin to leverage a broader picture of what are the factors that could contribute to a healthier community. It's focused on upstream and social and economic determinants of health, invites the entire enterprise to reimagine and unleash their potential as producers of health, leverages all of our Kaiser Permanente assets to produce health, and emphasizes coalition building and collective impact. You know, I'm somebody told me this, that Desmond Tutu once said, and I just love what the quote said. He said, at a certain point, we have to stop just pulling people out of the river, right? And go upstream to see why they're falling in the first place. And that's basically the whole concept of what we're trying to do with Cultivate. Moving upstream, trying to figure out, well, what is it? Why are we seeing this in our emergency room? Why are we seeing this, this deterioration in our members who shouldn't have deteriorated to this point, right? And remember, the hospital and the emergency room, we're sort of, in a lot of ways, the end point. So this concept of moving upstream is really very valuable, very important. There are lots of partnerships that we've been building, we've been trying to build with the school systems, because, after all, that's where it all begins. Health habits often are ingrained in school through public policy, through, physical activity programs, all of those kinds of things. And so we've been doing a lot of work with schools as well as other communities to begin to pull together the resources to make a difference. By the way, the medical office buildings, we used to build them all on campus, right? We'd have these big mega campuses with the idea that that's what people need. They need everything all in one place, in one, where they can access the hospital, the acute care, the specialty care, the primary care, the pharmacy, the health education, all of that. Well, in California, we cover a huge area, just a huge area. And the thing about it is that if you are all concentrated where our patients have to drive to us without adequate parking, right, Maggie? So I've heard you. You're not going to make that impact. It's not really inviting when you think about it. So if we're talking about life integration, we actually have to be out in the community. So for the last 10 years, we've actually had a very intentional decentralization strategy. In fact, we put a medical office building in South LA, and I think we're the first person to make that big investment in South LA in decades. There just haven't been, aside from Martin Luther King Hospital that's just about to reopen, there are just areas where, as an anchor institution, we could be a huge a galvanizing force for pulling the resources together. Anyway, you can see that it's common purpose, finding common purpose with other agencies, other interested parties in the community, going upstream, creating shared value, activate locally for the right reasons, have a collective impact, unleash potential, and really listen to the community stories about what they need in order to create the atmosphere that nurtures that health attitude. Now, finally, as you can see, this whole medical office building concept comes to our health hub, and this is how we're thinking about designing it and building in some of the tools that hopefully we'll actually begin to invest in as well. It's the evolved medical office building, blending efficiency with new operation models to achieve a value-added member experience. And these are sort of the core principles: vibrant and productive environment to enhance not only workplace wellness for our providers, but to elevate the member experience, right? That whole aspirational piece that I talked about, trying to really get people excited about health. And of course, intuitive and manageable for members, physicians, and staff, and embracing the community as a whole, and using these health hubs to play a vital role in improving the health of the entire community. One of the core principles is it should be enabled by technology. So most of us who've had, when I used to run the public hospital system in New York, I mean, they were massive crowds of people always waiting to get in, right? So, actually, if you actually notice, we call our medical office buildings MOBs, right? And that's what ambulatory care used to be: mobs of people coming I just remember my first job was running the medical clinic at Kings County Hospital, and people would line up in the morning half an hour before we opened the doors, because of the belief that first come, first serve, right? You get in early, and maybe you can make it home before dinner time, is what people thought. But technology allows us to really to give people the freedom to wander in a space where we can actually interface with our members in a different way, right? You don't have to register and go sit and wait because, as you know, our cell phone, we can text you when the appointment's available, and you can make the appointment online. You can register online, and Apple actually has you pay online. They just walk up to you, they give you this thing, and 2 minutes later you walk out, and you're a little poorer, but you're happier, right? So we have all of this built into these health hubs, and it's enabled by technology for both patients and providers. And our exam rooms are not typical exam rooms. This is actually what we're putting in. There are probably 6 projects that are going to be delivered sometime in the next year and a half, with another dozen being planned right now. And it basically, and when you think about it, most of the time it's a consultation room. So why make somebody, get onto this table, that's so off-putting in a lot of ways, right? So this is what it is. By the way, these chairs are designed so that they can flip back, and you can examine someone in the chair. Computers, right? Computers, instead of having computers, which are barriers now. If you have these computer stations where the doctor is constantly looking at the computer and typing, well, that's pretty off-putting if you're a patient. That's very, unless you're skillful at using it to engage your members and your patients, it can be very off-putting. All right, and in fact, that's what some of our members told us, that their visit is most of the time talking to the back of the doctor's head, right? So what we are going to design are video screens and tablets where it allows for greatest interaction, and our members, our patients, will see everything that's out there, and the doctor can begin to pull things up as they go. By the way, the other thing that's going to be available is video visit capability. So if you need a consultation, now I don't know about the workflows. The workflows are probably going to be hard, but let's say you have a question, or a patient has a question, and you need to get hold of a specialist. You could actually begin to beam those consultations in while the patient's in the room, right? So you could either do it while the member's there, or you can schedule it. There are lots of different venues there. And the doctor's offices are also going to be video enabled, so that they can actually have video visits off campus or off site with our members. Lots of tools that allow people to check in either on their own, either through mobile applications or on their own computers. They can pay. Hopefully, we'll know when they're there. We can check them in quickly, and then we're actually contemplating the ability to just not have waiting rooms, but have a big, gigantic public space where we can begin to engage with health education stations, with lots of demonstrations, perhaps cooking demonstrations. And we're so blessed with great weather in Southern California that we can actually open it up to the outside, where people can actually take a walk and saunter, rather than sitting there waiting for to be called, right? So all of this is we're capable of doing. And then, of course, questionnaires pre-visit and post-visit, we can actually do that. We're all fully capable of doing that at this point. So the first project is actually going to open up in September. One of the biggest projects in the Inland Empire will be available a year from September, and that's a 54 physician complex, right? So it's going to be huge. And basically, if you think about what we're going to be building, we're blurring boundaries, right? We're inviting our members to, to participate in the full panoply of activities, where we want it to be fully integrated with the community, kinetic and green. I mean, very important. We're in California, after all. We have to be totally correct about water and energy. We want to make the place alive with enthusiasm, aspirational, inspirational, and transparent and engaging. And the spaces have to be, vibrant and active, invite participation, and really be part of the community. By the way, these are pictures, but we're actually going to build, it's going to look pretty much like this with the color schemes and the rest. And then for the providers, rather than having, the typical one doctor office, 2 exam rooms set up, well, the doctor offices are in an enclave, and the provider space with the exam rooms encourages maximum interactions between all of the personnel that's going to be taking care of the member. Hopefully, these are the things that will happen. We'll really emphasize a real-time education, encourage conversations, right? Active conversations between our providers, the support and ancillary staff, and our patients, and hopefully we'll all be inspired to to be a creative force in the community for better health. And that is the vision that we have for the future. And these are the tools that we're actually beginning to put into place. I know our IT departments are trembling because, we said this is the opening date and all of these things have to be in place. And then, of course, we're leveraging existing tools, modules, that we already have. We have telephonic coaching that's available. All of those things have to be woven into a complete picture of how we want to deliver care, and actually dovetails very, very nicely into the overarching goal of interactive patient care that Get Well Network and Michael, I know, with the fire in his eyes, brought to us, I think at Haney's meeting, right? The Hospital Association of New York State. So it's really a pleasure to offer this as a way of beginning to think about it. Hopefully some of you can come visit us in a year or so and see some of these sites. It's really kind of exciting to think about how we can reimagine health and reimagine care and really put ourselves in a partnership arrangement with our communities and with our members to do so. So thank you very much. I actually will take questions if anyone has any questions, but thank you. Question? Yeah. There's a mic coming around to you.
Is this KP's organizational vision that's come about from within, or do you think it's federal government mandates that have pushed you in this direction?
No, it's actually from within. We've been doing a lot of work. This particular piece of the work is Southern California, but if I were to present to you some visioning work that the entire program has done, it actually completely fits in with all of the work that's been done. It's called Vision 2025, is what the program work is.
Well, I think that's very commendable. Mm-hmm. I think that shows what the private sector is capable of doing when left alone to innovate, plan, and implement it.
Yeah, well, I think that one of the reasons why we're able to do this, of course, is we're prepaid. I know many of you are hospital-based, and it's not easy, when the reimbursement stream is really tied to the episode, right? So here I'm talking about, well, how do we expand 24/7? how do we break out of our geographical limitations and build a platform for life integration, right, for health. But if we're not paid that way, it's hard to do. So I actually am very sympathetic to most of the healthcare providers out there, where it takes a lot more to say this is where we want to go, and to hope that the reimbursement streams will be there to support us, right? So I'm actually very sympathetic to that. But there are lots of people who are going to be able to do this. I mean, I know there are lots of people from the VA here. You know, you're capable of doing this as well, even though there are other issues around whether your members are only coming to you for care. I mean, I know that there's a lot of people who go to multiple venues. But we have a captive audience, right? We actually have a captive audience, and that gives us the ability to do this. But I do think that most healthcare institutions are beginning to think of themselves as anchor institutions, right? Not just a closed fortress where people have to break their way in to get the needed care. And the whole premise behind interactive patient care is that it's not one way. It can't be one way. And in fact, in a lot of ways, it should be driven from what the individual's needs are rather than, from what the provider needs are. Yeah.
Dr. Chu, first of all, thank you for sharing your thoughts. It's very inspiring. And the second thing is, we talk a lot here about measurement and about efficacy of some of these tools and how they're really impacting outcomes. Can you talk a little bit about the measures of success that you'll look to from the new programs?
First of all, we're always monitoring patient satisfaction, right? And of course, the nice thing about what we've been able to do is, we measure, and part of it is us measuring our own success in terms of clinical outcomes, but part of it is, actually more and more outside regulators asking us for the same things. And I will say that from a clinical point of view, in the last 10 years, we've gone from pretty mediocre in terms of health outcomes, control of high blood pressure, control of diabetes, those kinds of things, to really probably close to leading the pack nationally. And that's because of systems-like approaches. With life integration, this contemplates a whole different level, right? So it's not just about the outcomes for obviously, if you do this well, you'll have fewer people admitted to the hospital. You'll have fewer people with complications that could actually be avoided, and that's probably what we're going to measure. And in the end, it's really about total cost of care, right? Because if we're successful at leveraging outside partners to help us, the total cost of care should come down, and then patient satisfaction should actually increase. It's interesting because if you in the health plan world, so we're a little unusual. We play in the health plan space as well as the hospital space, as well as the ambulatory whole continuum space. In the health plan space, net promoter scores for health plans are dismally low, right? In some instances, they're actually negative. You guys know what the net promoter scores. Your highest patient ratings minus your lowest, right, is your net promoter score. So you can imagine if you have very few here and a lot here, you have a negative net promoter score. Well, health plans sometimes often do have net promoter scores that's that low. Our net promoter scores are hovering in the 40 to 50% range as a health plan, right? But if I look at the satisfaction scores overall, they're actually much higher overall. I mean, for the care side. So, those are the kinds of things we look at. Yeah.
First, thank you so much for that amazing talk. So I'm just finishing my master's in public health, and I wanted to say that so many of the things that you said mirror the Public Health Healthy People 2020 goals. And I was wondering, as one of the outcomes, have you seen any decrease in the healthcare, the health inequities related to
Sure.
your population?
Sure. So when you take care of 10 million people, especially in California, we have people of all huge diverse population. And when we actually started, by the way, the other thing that we weren't able to do before we put the electronic health record in is actually ask people, well, what ethnic group are you in, and analyze people according to that dimension. And in the beginning, there was disparities between African Americans, particularly for hypertension control, numbers of things like that. Hispanics, were dismally low in terms of colon cancer screening, to give you another example, and then a whole host of other things. Diabetes control was different. So what's happened with our system is that now we know, and we actually see over time, where people are, and because of our systems approach, right? It's, by the way, you can't address these things by just putting it on the backs of the doctors, right? If you believe what I say, that an average doctor only sees a patient no more than 4 times a year on average, you're not going to get the changes you want unless the entire system comes in and helps that doctor. I mean, think about it. If you have 2,000 patients and your average patient has 2 gaps that they should be meeting, that's 4,000 gaps. I mean, what's a poor doctor to do? There's no way one person can begin to address that. So we use a systems approach to trying to address that. And I have to say that just about all of the measures that we measure on, like HEDIS measures for blood pressure control, diabetes control, and all of the other things that are in there, the gap has actually come down. And in fact, for just about all, I think there may be one measure where African Americans are still below the 90th percentile in terms of level of control. But the gaps are within 2 to 3 percentage points. And I don't know if you, some of you may have seen that New England Journal article that looked at Medicare Advantage plans and over the last decade or so. And the only region that has actually shown no gaps between different minority groups and the dominant population was the Western region, primarily because of California. And I think that it's primarily because in Kaiser Permanente we've eliminated a lot of those disparities and elevated the overall performance. So, it really is about an intentional, systematic approach to dealing with this, right? Other questions? Well, I hope this sort of stimulated your thinking, because think about it. If
I had just one question. I'm so sorry to interrupt.
Where are you?
And I'm from Kaiser, so you'll have to answer my question.
I will always answer your question.
So I'm particularly interested in your nurse-run clinics. You mentioned that you had 2 in San Diego, 1 in the Inland Empire, and 1 fourth one, but I can't recall the location.
1 in Orange County.
Yes.
County.
So how do you make a determination around what would best be suited for the population in terms of a nurse-run clinic versus setting up MOBs that are provider-based? And by provider, I mean physician-based.
Right.
How do you make that differentiation in terms of meeting the needs of the population?
Well, there are a couple of ways we're looking. First of all, the target clinics are just an experiment. We actually have two clinics with Walmart as well. 1 in the Antelope Valley and 1 in Kern County. So right now in Southern California, there are 6 sites where we're testing out different models. And the one in Kern County and Antelope Valley is actually a nurse staffs it, but a good chunk of the care is through telehealth, video linkages to doctors. So there are different models that we're trying out at this point. I think that we're just experimenting right now, and the underlying premise is we want to get as many sites off campus as possible. And I assume, are you from Northern California? Yes. Well, how about it? Well, you know that the model is very expensive. Every time you want to build a medical office building, it's millions of dollars. I know your San Francisco medical office building rebuild is a couple $100 million actually. So, and ours are easily $50 to $60 million for large physician complexes. This idea of, if we're serious about getting out into the community, which we have been in Southern California, just about all of our medical office buildings are decentralized off the campus now. This is just another way of getting smaller ones even further out into the community. And we'll have to look at it one at a time. I have to say that in Antelope Valley and in Kern County, the experiment hasn't really worked out that well, right? And there are a lot of reasons for that I can talk about with you if you want to. But in the target sites, it's been wildly successful. I mean, it just in the 4 or 5 months that we've operated it, there's been a lot of demand both from members and non-members. So there are lots of different ways of doing it, but basically you have to embrace the idea that you want to be in the community in a very intentional way, and that's how we do it. I hope that answers your question. Okay. Well, thank you very much, everyone. Take care. Have a great conference.